This is what you don't want to have if you have a prosthetic valve: vegetations and endocarditis. It's not completely clear why prosthetic material, in particular in prosthetic valves, predisposes to bacterial infection. But it is probably related to several factors which vary depending on when endocarditis occurs. If it occurs less than 60 days after surgery or after 60 days. And basically, this is also the way we classify prosthetic valve endocarditis. So, let's take a look at what the mechanisms are in the specific situations. In early endocarditis, it is usually caused by some form of hematogenous spread, or sometimes also by direct contamination, where the bacterial infection travels or passes along the suture lines and the sewing ring. One major problem we have in the situation is that we do not yet have endothelialization of the prosthetic valve. So that is the main risk factor for endocarditis shortly after operation. In the setting of late prosthetic valve endocarditis, the mechanism resembles more that of native valve endocarditis. Here we have some form of endothelial lesion, which is, for example, caused by degeneration of a bioprosthetic valve or maybe some form of jet lesion. Or we also have thrombus formation. And this represents a predisposition for bacterial infection and thereby causes endocarditis. In comparison to early prosthetic valve endocarditis, late endocarditis usually does not cause such severe forms of destruction, especially perivalvular involvement. However, this does not mean that patients with late endocarditis cannot also have very severe forms and also a lot of complications, as you will see later. Here are some facts to remember. Prosthetic valve endocarditis is a life-threatening complication which has a high in-hospital mortality, somewhere in the range of 22.8%. It can affect both mechanical and bioprosthetic valves. And we see more and more prosthetic valve endocarditis cases, probably related to the fact that we have more implants now and that we also have an aging population. Here are some risk factors for prosthetic valve endocarditis: heart failure, especially advanced forms, wound complications, alcohol consumption, a prior history of endocarditis, fever on the ICU, and also gastrointestinal bleeding. In general, prosthetic valve endocarditis is characterized by three different problems. It is difficult to detect because very often we have artifacts. We can have severe complications, and it is difficult to treat. Here's an example of a prosthetic valve endocarditis where you can only discretely see a vegetation here on the prosthetic valve. Very often you will also need a TE study to verify the diagnosis and to see the true extent of the problem. You should always have the suspicion of endocarditis in the setting of a prosthetic valve and fever, especially if you also find embolism, valve destruction, or structures on the prosthesis. But then again, it is also very important to compare these structures with previous echocardiographic findings. So again, just to emphasize, you should always have a baseline study available to compare the study with. Sometimes it's really difficult to make the diagnosis, especially if you find structures like these here. In this case, it was subvalvular residuals. But you can also have problems in the differential diagnosis to artifacts, surgical material, strands, or thrombi. So, as I mentioned earlier, very often you will need a TE study or follow-up studies to confirm your diagnosis. And it's so important to make the diagnosis early because the longer the endocarditis is active, the more complications you will get. What kind of complications can you find? Well, periannular abscess formation, pseudoaneurysms, we talked about those already in the chapter on prosthetic valves, paravalvular leaks, valve dehiscence, and valve obstruction. Here are some examples. On the left-hand side, we see a patient, a 70-year-old patient who received a mechanical prosthetic valve 6 years ago. And when she came, she was in septic shock actually, with high-grade fever and also with this large structure here, lateral to the prosthetic valve. If you look at the motion of the prosthetic valve, you can see that there's actually a rocking motion, so there is partial dehiscence. You can almost sense the perivalvular regurgitation here. This is a beautiful example that even in late prosthetic valve endocarditis, we can have severe complications. This patient unfortunately died. She did not make it to reoperation. Here we have a patient who had early endocarditis following also a mechanical prosthetic valve. Here we see the structures, the vegetations located on the sewing ring. Remember, from the transthoracic approach, there is no way we can really see these structures simply because we have shadowing due to the prosthetic valve itself. So this again shows you the advantage of transesophageal echocardiography. This is another transesophageal study, but of a different patient. But again, we see a vegetation here on the sewing ring. But this time, this vegetation also causes obstruction of the bileaflet valve. So here we have another form of complication, obstruction of a prosthesis. This example shows you another form of dehiscence, this time in a biological prosthetic valve. You can even see the vegetations here. And just looking at the motion of this bioprosthetic valve, this is by the way a transthoracic study, you have the impression that the valve will detach itself completely any minute. She was operated only hours later and everything went fine, and she left the hospital only 3 weeks later. And here's another example, this time of a patient with a biological aortic valve with a perivalvular abscess formation, and also with infection which passes through this abscess formation into the right atrium. Here we have another vegetation located in the right atrium. So severe infiltration of the ring with spread of the infection to another chamber. This can be nicely seen also here in this detailed view of the same patient. Here is the abscess formation, and here is the structure. And what do you think of this case here? Does this patient have endocarditis? Well, what we have here is we have a very thick aortic root. But the question is this abscess formation? To give you the answer, yes. Also take a look at the aortic valve, the prosthetic valve, and you can see that there is a small vegetation here, a mobile vegetation. You have to look very closely to see it. In addition, we have paravalvular aortic regurgitation. To give you the history of this patient, a 65-year-old male who had very high infective parameters and a positive blood culture for Staph aureus again. So we had to reoperate this patient. The diagnosis of endocarditis is much easier in this setting. A patient with a aortic bioprosthetic valve, and you can see that there is a pseudoaneurysm, a pulsating structure here in the intervalvular fibrosa, but also here, located in close vicinity to the right ventricle. So, even though we do not have any vegetations, or only small vegetations maybe here, this is highly suspicious for the presence of endocarditis. Also note that the tissue of the valve is significantly thickened. We have now seen several examples of aortic and mitral prosthetic valves with endocarditis, but we can also have endocarditis on a tricuspid prosthesis. Remember, we don't really implant tricuspid prosthetic valves very frequently simply because we always try to reconstruct the valve first. But sometimes, especially in the setting of drug addicts, where the valve can be severely destructed, it is not possible to reconstruct the valve anymore. Here we have such an example. A patient who had recurrent tricuspid valve endocarditis and then received a tricuspid valve prosthesis. But unfortunately, again, she has endocarditis, this time of the prosthetic tricuspid valve. We can see the vegetations here. The severely destructed prosthetic valve, there's almost no tissue left. And also, with the help of transthoracic echocardiography, we can see mobile structures here on the lateral vicinity of the prosthetic valve. So this example showed you that we can have endocarditis on prosthetic material in the right heart. But valves are not the only prosthetic material where we can find vegetations. We can also find them on pacemaker leads. And this will be the topic of the next chapter.